So welcome along to this presentation where we'll be discovering some of the ventilation modes, giving an overview of the indications for ventilation and a brief talk on how mechanical ventilators actually work. So what is a mechanical ventilator? Well, as we know from our first lecture, a pressure gradient is required for air to move from one place to another. And during spontaneous ventilation, inspiration results from the generation of the negative intrapleural pressure from the contraction of the diaphragm and the intercostal muscles, which draws air from the atmosphere across the airways and into the alveoli. During mechanical ventilation, inspiration results from the positive pressure that's created by compressed gases through the ventilator, which pushes air across the airways and into the alveoli. In both spontaneous and mechanical ventilation, exhalation results from the alveolar pressure generated by the elastic recoil of the lung and the chest wall. The pressure necessary to move a given amount of air into the lung is determined by two factors: the lung and chest wall elastance and airway resistance. And mechanical ventilation is not intended to normalise gas exchange, nor is it a cure. The goals are to maintain sufficient oxygenation and ventilation to ensure tissue viability until the disease process that has compromised the patient's lung function has resolved, while minimising any complications. Thus, PaO2, PaCO2 and pH levels are maintained in ranges that provide a safe environment for the patient, while protecting the lungs from damage caused by oxygen toxicity, pressure or barotrauma, tidal volume over distension, volutrauma, atallec trauma and cytokine release or biotrauma. Non-invasive positive airway pressure ventilation, or NIPPV, provides positive airway pressure during exhalation, and bilevel modes can apply additional positive pressure during inspiration. Using NIPPV in the setting of respiratory failure, which is either caused by hypoxemic or hypercapnic respiratory failure, is generally considered for patients who have a condition in which there is the potential for it to rapidly improve the decompensated physiological variables. To initiate invasive mechanical ventilation, we typically need to have in place an artificial airway, such as an ET tube, which will act as the interface between the mechanical ventilator. Now, the three most common and rational indications for mechanical ventilation are 1. Inadequate oxygenation, 2. Inadequate ventilation, and 3. The inability to protect the airway. There's a couple other potential causes to put a patient on a ventilator, such as a anticipated clinical course, but these are generally the main reasons we'd be going onto a ventilator. Now, oxygen failure is typically associated with hypoxia. A shunt occurs when alveoli are perfused but not ventilated, as in pneumonia, acute respiratory distress syndrome, acute lung injury, pulmonary hemorrhage or pulmonary contusion, and atelectasis. Dead space ventilation results when alveoli are ventilated but not perfused, as in pulmonary embolus, hypertension, and low cardiac output states, such as cardiogenic shock. Oxygenation depends on the ability for the oxygen to diffuse from the alveolar membrane into the capillary blood. However, diffusion abnormalities can prevent this from happening normally. Diffusion abnormalities are caused by the obstruction or restriction of gas exchange across the capillary alveolar membrane, as in pulmonary edema or pulmonary fibrosis. Inadequate oxygenation can also occur because of an inability of the cells to extract oxygen, and we see this in sepsis, carbon monoxide poisoning, or cyanide poisoning. Ventilation failure, also called type 2 respiratory failure, is essentially an inability to remove CO2. We have inadequate ventilation. And this can be a cause from neurologic causes such as spinal cord injury, traumatic brain injury, overdose, and other conditions where the muscles are weak, such as Guillain-Barré syndrome. Muscular abnormalities resulting in myopathy from myopathies or myasthenia gravis can also contribute to the failure of the patient to ventilate. Finally, anatomic causes such as pleural effusions, hemothorax, pneumothorax, flail chest, and abdominal hypertension may impair ventilation as they restrict the movement of the chest wall. A patent airway is essential for adequate ventilation and oxygenation. If a patient is unable to maintain a patent airway, patency should be established by using any airway maneuver you can to reposition, such as a chin lift, jaw thrust, or inserting an oral or nasal airway. Likewise, the patient must be able to protect themselves against aspiration of gastric content, which carries significant risk for morbidity and mortality. Historically, the presence of a gag reflex has been advocated as a reliable indicator of the patient's ability to protect the airway, but this has been definitively proven to be unreliable because gag reflex is absent in 12 to 25% of normal adults, and there's no evidence that its presence or absence corresponds to airway protective reflexes or predicts the need for intubation. The patient's ability to swallow or handle secretions is a more reliable indicator of airway protection. The recommended approach is to evaluate the patient's level of consciousness, ability to phonate in response to voice command or query, which provides information about the integrity of the upper airway and level of consciousness, and the ability to manage their own secretions. So if we see pooling of secretions in the oropharynx, or are they able to swallow spontaneously or on command. In general, a patient who requires a manoeuvre to establish a patent airway, or who easily tolerates an oral airway, requires intubation for early airway protection, unless there's a temporary or readily reversible condition such as opiate overdose. And finally, one of the other conditions would be for the anticipated clinical course. So certain conditions indicate the need for intubation, even without an immediate threat to airway patency or adequacy of ventilation and oxygenation. And these conditions are characterised by a moderate to high likelihood of predictable airway deterioration, worsening physiological derangement, or the need for intubation to facilitate a patient's evaluation and treatment. Intubation may be indicated relatively early in the course of some overdoses. So, how do ventilators work? Well, positive pressure ventilators accomplish the task of creating the inspiratory force through positive intrapulmonary pressure. That is, air is forced out of the ventilator through a drive mechanism such as a piston, bellows, high gas pressure, or a turbine, and this raises the pressure in the airways relative to the atmospheric pressure, with the resultant increase in intrapulmonary pressure forcing the lungs to expand. Positive pressure ventilators first began to appear in the 1950s. From that time until today, they have undergone many changes, but can be distinguished by the type of controlling mechanism used in their drive systems. And this can be seen in three distinct generational changes. The first generation of positive pressure ventilators were characterized by pneumatically controlled drive mechanisms. Additionally, these devices used pneumatic timers and regulators to apply pressure to the lungs. In the late 1960s, ventilators began to be manufactured that incorporated analog and electronic technology to refine their control elements. These devices comprised the second generation of ventilators. And then the third generation of ventilators appeared on the market in the early 1980s with the advent of the microprocessor. With the incorporation of microprocessor technology, ventilators can now offer even greater control over their delivery systems, they were safer to use, and they consume less power. Today's ICU ventilators have a multitude of settings and variables. Now, our aim of providing mechanical ventilation, we're aiming to maintain the normal function of ventilation. Recall from earlier presentations that the role of the respiratory system is to provide oxygen delivery to the body and to remove carbon dioxide. Because IPPV is not physiological, we also need to take care not to cause damage to the lungs. Damage can occur due to high pressures resulting in barrier trauma, large breaths resulting in volume trauma, or repeated collapse and inflation of the alveoli, and this is called atelectasis trauma. Our lungs have a total capacity around 5 to 6 litres. That's if we take a large breath and keep breathing in until we can't do any more. However, we don't breathe in this manner. Recall that a tidal volume breath is around about 400 to 500 mils, and this also leaves a residual volume of 2 to 2.5 litres at the end of expiration. This is called the functional residual capacity, or FRC. Mechanical ventilators have several modes of ventilation that deliver breaths based on three preset factors called the trigger, target, and termination. Now the trigger is how the breath is initiated, which could be a ventilator initiated based on a preset time or rate, or it could be patient initiated based on negative pressure generated by the patient. Target is a preset inspiratory flow rate or pressure limit that the ventilator targets to generate that breath. And then termination is the endpoint of the inspiratory breath, which could be a preset duration of inspiration, a volume target, or a rate of respiratory inspiratory flow. And there are two broad categories of mechanical ventilation and how we determine our breath strategy. So one is volume control or volume limited, and these volume limited breaths target a preset flow rate, and inspiration is terminated when a preset volume is achieved. Airway pressures are determined by the intrinsic resistance of the circuit and airways and lung compliance. Pressure control is another mode of operation as well, and here we're targeting pressure limited breaths to a set preset inspiratory pressure. and so inspiration is terminated when a set inspiratory time is achieved. Tidal volume and ultimately minute ventilation are variable and depend on lung compliance and airway resistance. The three most commonly used modes of mechanical ventilation are assist control ventilation, SIMV, and pressure support ventilation. Each mode describes whether a breath's a volume constant or pressure constant, which breaths are mandatory or spontaneous, or both, and which variables determine a change in function. All three modes have uses throughout the spectrum of stabilisation of ventilation, maintenance of ventilation, and weaning from mechanical support. The choice of mode of mechanical ventilation is most often determined by whether resting of the respiratory muscles is indicated, such as the patient who is hemodynamically compromised, patients with severe oxygenation or ventilation derangements, or those undergoing general endotracheal anaesthesia. In these cases, such as in the pre-hospital environment, most patients will be RSI'd and hence require a mode of ventilation that accomplishes ventilation without the need for spontaneous respirations, so ACV is often the most commonly used mode. However, if the use of muscles or respiration is desired, SIMV or pressure support could be considered as well. Patients in whom the use of respiratory muscles is desired are usually those being weaned from mechanical ventilation or undergoing assessment of muscle strength and adequacy of spontaneous record breathing. Pressure support ventilation is the only mode of the three that relies entirely on the patient spontaneously breathing, and this will be uncommon in the pre-hospital environment usually. Control mode ventilation is the original mode of ventilation. In CMV, the patient receives a positive pressure breath at a set rate without the ability to influence how it's delivered. By choosing either volume or pressure ventilation, we can determine the control variable that is used to deliver the gas flow to the patient. Control variables are independent variables. In volume controlled ventilation, for example, the volume selected is constant and independent of what happens to the pressure when the patient's lung characteristics change, or when the patient's effort changes. The selection of using volume controlled or pressure controlled ventilation is based on whether consistency of tidal volume delivery is important or limiting of pressure delivery is important. It should be noted that the modes available also depend on the ventilator used in your service. The Hamilton T1 utilises a number of ICU modes of ventilation, while the Meduvent recently purchased by St John has only IPPV and CPAP as standard. And here we discuss some of the advantages and disadvantages of each mode of ventilation. So the advantages of assist control mode is that we have predictable tidal volumes, we can set a mandatory respiratory rate, it's useful for reliable ventilation, good for stabilisation of hypoxemia, and decreases the risk of breathing. The advantages of SIMV is it's more comfortable and allows respiratory muscle work. So if your paralysis begins to wear off and the patient's in SIMV mode, they're not going to be bucking against the ventilator. Pressure support modes don't really exist probably in the pre-hospital environment unless you do happen to have a Hamilton. But again, these are more comfortable and they allow for evaluation of spontaneous record breathing. So the patient is generating their own breaths and we're just basically providing some pressure support to augment that breath. The disadvantages of ACV, well, it can be uncomfortable for an awake patient, so your patients need to be really well sedated and really well paralysed. And this is the mode we're probably most likely going to be using for patients that are RSI'd in the pre-hospital environment. It's possible to get a respiratory alkalosis, so by overventilating your patient. Breath stacking and auto-PEEP are also of concern, particularly if we're not allowing enough time for expiration to occur. The disadvantages of SIMV is that spontaneous breaths can vary and it does increase the weaning time. So this isn't really a factor for us in the pre-hospital environment, it's more of a consideration in the ICU long term for a patient. And the disadvantage of pressure support, well, there's no guarantee that you'll be able to achieve the desired minute volumes. Now some ventilators will allow you to bring up flow, volume and pressure waveforms. So we can see here that the top graph represents a pressure waveform with a volume or exponential shark fin waveform, and typically a ventilator display will show the flow below the pressure curve. A decelerating flow pattern is often seen, and we can see that as we have a increase in flow, that flow begins to slow down towards the peak of inspiration. To explain this further, gas flow between the patient and ventilator is represented by the flow versus time scale. Inspiratory flow is a positive value on the graph, whereas expiratory flow is a negative value. The area under the curve represents the volume moved during the phases of breathing. The shape of the inspiratory limb of the curve depends on the mode of ventilation. In pressure-targeted modes, the peak inspiratory pressure, PIP, and the inspiratory time are set and flow is variable. In the beginning of the breath, flow is delivered at a high rate but then tapers off over the course of inspiration, resulting in a decelerating shape of the curve. Pressure-supported modes may also have a flow pattern that is decelerating or sinusoidal in shape. In volume control or flow-targeted modes, the tidal volume, inspiratory time, and inspiratory flow are set, resulting in a constant flow or square shape to the flow scalar. The use of one type of flow pattern versus another is usually clinician preference. In volume control modes, flow is constant until the goal tidal volume is achieved, resulting in a constant rise in the pressure and a higher peak inspiratory pressure, but a lower mean airway pressure. Controlled mode ventilation, CMV, is the original mode of ventilation, and in CMV the patient receives a positive pressure breath at a set rate without the ability to influence how it is delivered. The volume-controlled CMV gives you the optimal control over your minute volume. If you're trying to maintain a very narrow CO2 range in a paralysed sedated head injury patient, this would be a good choice. Of course, if they wake up, they'll start fighting the ventilator, coughing and bucking weirdly against it. It is an uncomfortable mode of ventilation for anyone who's even slightly awake. Volume assist controlled ventilation is a combination mode of ventilation in which a preset tidal volume is delivered in response to the inspiratory effort, or if no patient effort occurs within a set period. The period is determined by the backup respiratory rate set on the ventilator. A patient trigger breath is sensed by the change in airway flow or pressure, and when the change reaches the trigger threshold, the ventilator delivers the predetermined tidal volume. In ACV, the limit variable that increases to the set threshold before inspiration ends is volume or flow or both. The cycle variable that ends the inspiration is the volume or time. So peak inspiratory airway pressure and plateau pressure are variable in this setting. In patients with deep sedation or neuromuscular blockade, the ACV functions more like a controlled mode ventilation. The advantage of ACV is that it substantially decreases both worker breathing and myocardial oxygen demand. The disadvantage of ACV in the active patient is that it is less comfortable than spontaneously breathing, and that it can induce respiratory alkalosis and breath stacking if the threshold is set too low and the patient is triggering their own breaths frequently. Similar to VACV, the pressure-targeted ACV mode requires an input of the desired frequency, so respiratory rate, PEEP, and FiO2, but instead of a preset tidal volume, the upper limit of the inspiratory pressure that is allowable is set. So we're setting a pressure limit essentially. As the ventilator delivers a breath, the inspiratory flow continues until the maximum pressure or allotted time is reached, and the flow then ceases. In pressure-targeted ACV, the tidal volume varies and consistency is sacrificed to prevent barotrauma by high pressures. So we can have inadequate tidal volumes in this particular mode if the pressure or the lung compliance is too high. In volume-controlled ventilation, airway pressures can vary. With patients with severe hypoxemia from ARDS or requiring high PEEP and FiO2 settings to maintain adequate oxygenation, the airway pressures that are generated to deliver the desired tidal volume will increase. This increasing pressure can be measured as the peak inspiratory pressure, the mean airway pressure, or the plateau pressure, all of which attempt to describe the pressures that are transmitted through the airways at different levels and at different points in the respiratory cycle. As the plateau pressure increases, reflecting increased alveolar pressure, it may be prudent to use a more pressure-controlled variant of ACV. The primary advantage of volume-controlled ventilation is that it guarantees a specific volume delivery and volume of expired gas, regardless of changes in lung compliance and resistance or patient effort. The goal of volume-controlled ventilation is to maintain a certain level of PaCO2. Because we're delivering a set volume, there's also less chance of delivering hypoventilation. The main disadvantage of volume-controlled ventilation is seen when the lung condition begins to worsen, and this can cause the peak in alveolar pressures to rise, leading to alveolar overdistension. In the image on the slide, we see the graphs for constant flow, volume-targeted ventilation, with normal compliance in picture A, reduced compliance in picture B, and increased compliance in picture C. Note that the inspiratory flow is above the x-axis, and the expiratory flow is below the x-axis. Similar to volume-controlled ventilation, the pressure-targeted modes require an input of a desired frequency, say respiratory rate, PEEP, and FiO2, but instead of a preset tidal volume, the upper limit of inspiratory pressure that is allowable is set. As the ventilator delivers a breath, the inspiratory flow continues until the maximum pressure or allotted time is reached, and then the flow ceases. In pressure-targeted modes, the tidal volume can vary, and the consistency is sacrificed to prevent barotrauma by high airway pressures. Viewing the graphs on the slide, we can see the effect of lung compliance on the delivery of volume. So the main disadvantages of pressure-controlled ventilation include that the breath volume can be affected by changes in compliance. So if our compliance is suddenly reduced, such as from bronchospasm or abdominal compartment syndrome, this can result in a lower tidal volume being delivered. Less volume delivered can then lead to hypoxemia or hypercapnia. Conversely, if our compliance is suddenly increased, then we have less resistance, so therefore higher volumes at a set pressure can be given, and this can potentially lead to volume trauma. Synchronized intermittent mandatory ventilation is a frequently used mode of ventilation in most medical and surgical units that incorporates characteristics of ACV and PSV. SIMV requires the same settings as ACV, so we're setting a frequency, a tidal volume, a PEEP, and FiO2. However, it also includes a setting for a prescribed pressure support for a spontaneous breath. The purpose of the two types of breath, like mandatory and spontaneous, is to allow increased diaphragmatic activity and increased work of breathing by the patient when triggering spontaneous breaths. When a patient is deeply sedated or paralysed, SIMV functions pretty much like an ACV mode. The patient receives a fixed number of mandatory breaths as determined by the set respiratory rate with a set tidal volume, PEEP and FiO2. However, if they're generating a spontaneous ventilatory effort, then SIMV will assist the patient when a mandatory breath is triggered and support spontaneous breaths above the set number of mandatory breaths required. The advantage of this mode is that it allows the patient to receive a fixed number of mandatory breaths by controlling the breaths or assisting the breaths if the patient is triggering the start of the inspiration, and the patient is allowed to breathe spontaneously at a higher frequency than the set rate. The use of SIMV may reduce sedation requirements. In the ICU, SIMV is sometimes used as a weaning mode, but it can prolong mechanical ventilation and is therefore not routinely recommended for weaning. The pre-hospital utility is that as muscle relaxation begins to wear off, it leads to less ventilator dysynchrony. Pressure-regulated volume control is a control mode of ventilation that combines features of pressure-controlled and volume-controlled ventilation, and it can be employed with ACV or SIMV. With PRVC, a target tidal volume is set, but the breaths are delivered with a decelerating ramp flow pattern, as in pressure-controlled ventilation. The ventilator provides a breath at a low pressure and then calculates the peak pressure necessary to deliver the set tidal volume. That pressure level is delivered during the next breath. If a target is not attained, the peak pressure is adjusted by 1 to 3 centimeters of water for the next breath. This allows breath-to-breath correction and enables increased airway pressure control. Because the inspiratory flow is auto-regulated, PRVC results in a lower peak airway pressure with a given tidal volume. Because the ventilator responds to a patient's effort in PRVC, as the patient's respiratory effort increases, the inspiratory pressure will decrease, therefore allowing for the patient's increased work of breathing. The PRVC can also be useful when a patient is not breathing spontaneously because it delivers a guaranteed tidal volume with a decelerating ramp inspiratory flow pattern, which minimises the peak inspiratory pressures generated. Many modern anaesthesia machines will have this particular flow mode on them, as well as the Hamilton T1. It is an option that's available on the Meduvent, but is currently switched off. Whilst it's unlikely to be used in the pre-hospital setting, pressure support ventilation is used for patients who are awake enough to accomplish spontaneous breathing. PSV was initially developed to reduce the work of breathing in SIMV, but evolved into a standalone mode of ventilation. Pressure support ventilation augments a patient's spontaneous respiratory efforts with a selected level of peak airway pressure. The inspiratory pressure is delivered until the flow decreases to a predetermined level, usually about 25% of the peak flow. PSV allows the user to control the desired pressure support, PEEP and FiO2. This mode relies entirely on spontaneous breaths by the patient, who must have an intact ventilatory drive. The work of breathing of PSV is inversely proportional to the level of pressure support and the flow rate. Because no tidal volume is guaranteed by this mode of ventilation, pressure support must be titrated to allow the patient to achieve an adequate tidal volume. However, any change in lung compliance or airway impedance results in a change in tidal volume. A certain level of pressure support is needed to overcome the resistance of the ventilator circuit and endotracheal tube. This is typically less than 10 centimeters of water, although it can be higher with narrow tubes. Pressure support above that needed to overcome the artificial airway resistance supplements the achieved tidal volumes. Typical pressure support settings are 5 to 25 centimeters of water. When full ventilatory support is needed for a patient, PSV may not be the ideal mode because it requires a higher work of breathing and minute ventilation is not guaranteed. Volume guarantee ventilation is a volume targeted modality that can be applied to assist control, SIMV, or pressure support. Volume guarantees a pressure limited, volume targeted time or flow cycled ventilation mode. It allows adjustment of inspiratory pressure to changes in exhaled tidal volumes, therefore compensating for any air leaks around uncuffed ET tubes. Volume guarantee has been primarily used in neonates and is shown to be both feasible and effective. Again, volume guarantee ventilation probably isn't really available to us in the pre-hospital environment, but it is something you may see during your rounds in ICU or ED. And finally, just a discussion on non-invasive ventilation. So we have two modes essentially of non-invasive ventilation. We have CPAP, which provides a continuous positive airway pressure, and the best way analogy for this is that if you stuck your head out of the car window driving at 100 km an hour, that constant flow is like a CPAP. BiPAP stands for biphasic positive airway pressure, and this improves oxygenation and ventilation, whereas CPAP only improves oxygenation. So moving on to CPAP, as we said, CPAP helps improve oxygenation. During CPAP, the ventilator or CPAP machine forces a continuous column of compressed air at a fixed designated pressure against the face and nose of the patient who is wearing a mask or nasal cap. When the patient's glottis opens to inhale, that pressure is transmitted throughout the airway, helping to open it. There's no inspiratory flow of air from the CPAP machine. Whatever additional tidal volume the patient pulls in is from the additional airway volume recruited by this pressure. When the patient exhales, pressure from the deflating lungs and chest wall pushes air out against the continuous pressure until the two pressures are equal. The air pressure in the airway at the end of exhalation is equal to the external air pressure of the machine, and this helps to splint the airway open, allowing better oxygenation and airway recruitment. If the CPAP is set too high for the patient, exhalation becomes very uncomfortable, since the patient has to push against the pressure to exhale. This can increase the work of breathing for the fragile COPD patients or weak critically ill patients. Positive end expiratory pressure is the pressure present in the airway, or alveolar pressure, above atmospheric pressure that exists at the end of expiration. The term PEEP is defined in two particular settings: extrinsic PEEP, or PEEP applied by a ventilator or bag mask, and intrinsic PEEP, PEEP that is caused by a non-complete exhalation that causes progressive air trapping. Applied PEEP is usually one of the first ventilator settings chosen when mechanical ventilation is initiated, and the application of PEEP has two primary purposes. One, it increases lung volume in patients who have acute lung restriction in order to improve arterial oxygenation by recruiting or stabilizing alveolar units, and to protect the alveoli against injury during the phasic opening and closing of atelectic units that produces hypoxemia. It also reduces the effort required for patients to trigger the ventilator or breathe spontaneously in the presence of dynamic hyperinflation and auto-PEEP. Applying PEEP increases alveolar pressure and alveolar volume. The increased lung volume increases the surface area by reopening and stabilizing collapsed or unstable alveoli. PEEP therapy can be effective when used in patients with a diffuse lung disease with a decrease in FRC. PEEP and IPPV both contribute to a rise in intrathoracic pressure, and this can contribute to hypotension after placing a patient onto a ventilator. Now, going back to BiPAP, BiPAP has two levels of continuous airway pressure. When the machine senses the patient's inspiratory flow starting to increase, it increases the inspiratory pressure, or IPAP, applied so the airflow is enhanced and the patient's own inspiratory tidal volume is augmented. When the machine senses flow is stopping or slowing, it reduces the applied airway pressure so the patient has less work upon exhalation, but maintains a constant continuous positive airway pressure, or expiratory peak airway pressure, EPAP. This allows the patient to receive higher inspiratory pressure, but not have to work against higher expiratory pressure. In addition, the machine can be set to deliver a fixed respiratory rate. Airflow is generated until the airway pressure is sensed by the machine reaches a set target inspiratory pressure. The tidal volume received by the patient depends upon airway resistance, lung and chest wall compliance, patient synchrony with the machine, and the absence of air leakage around the mask. BiPAP can only augment the patient's respiration and should not be used as a primary form of ventilation in a sedated paralysed patient. And we'll try and dive more into the use of NIV in another series of presentations.